The other thing that has changed a lot over time is when we start treatment. So Colleen, I don't know, I can remember these debates we would have about CD4, above this, below that, should we, where are we now in terms of giving therapy?
I think I've actually seen you debate that at one point several years ago.
Probably on both sides of the
debate.
debate.
That's right, that's right. Well, it's now very simple, right? So anyone who is HIV positive deserves HIV therapy. And so we don't worry anymore about whether someone's CD4 count is high or low. We offer therapy to everyone. And so it makes it a whole lot easier when you have those discussions.
Yeah, I think that's really critical for primary care providers, because maybe if, maybe they're have listened and they're going to do more testing and they're finding people that are positive, maybe their comfort level ends there and they want to refer people for care. So I think knowing that anybody who's positive should be treated. I mean, are there exceptions, Dan? Or?
Well, there really aren't. I think there's no emergency in starting therapy for most patients unless they're presenting very late in the course of disease. But if somebody is reluctant to go on treatment, if somebody is temporarily in a chaotic life situation, you may take some time to get things stabilized, to get to know the patient well, to reassure them about the tolerability of the treatment and get them to accept treatment. But that should be the minority of patients and the exception rather than the rule. I think for most patients, we really do want to get them on treatment really at the time of diagnosis. And there have been more and more efforts in California, New York, in Boston as well, to try and do same-day initiation of antiretroviral therapy, because that's the best way to prevent somebody falling through the cracks and falling off the cascade.
Yeah, I think we mentioned this before, but kind of treatment as prevention. We didn't really get into that. Maybe we should get into that a little bit here. That's kind of
that's what I was saying as we were talking about this. I think the simplicity is nice. Yeah, treat everybody if they're willing. But the reason why we treat everybody is, to me, the best part is, right, we now have overwhelming data showing that even in people with high T cells, that they benefit from early therapy. They have less adverse outcomes. So that's really good. And then there's the prevention part. We have this amazing data showing that if somebody's viral load is suppressed, their risk of transmitting to a partner is extremely small and approaching zero for that person who is stably suppressed for 6 months or more, takes their medications consistently. So there's the personal benefit, there's the public health benefit, and then really, to me, the biggest factor that allowed us and is allowing us to have this conversation is how good treatment is, like Dan was talking about. I mean, we're now, when we start someone on therapy, we're telling them you're gonna take 1 or 2 pills a day probably, with virtually no side effects, and frankly, if you have any, we can switch to one of the other options. And in these randomized controlled trials of early versus delayed therapy, the positive outcome is that you have less events, adverse events, as far as AIDS progression and things. But the other finding is that if you compare adverse events between those on therapy and not, there's no difference.
Right.
Because our drugs are so well tolerated.
Yeah.
And I think a really critical issue about the clinical trials that showed the benefits of early initiation, even at high CD4 counts, was that even at high CD4 counts, the people in the placebo arm had opportunistic infections and had events, particularly malignancies, that we typically associate with more advanced disease. So although it's hard to identify which patients are most at risk for those adverse events out of a large group of patients, the take-home message is that everybody needs to be treated, because even at high CD4 counts, people with HIV infection are still at risk for adverse medical outcomes.
In the famous START study, 2/3 of the events occurred in people with CD4s of over 500.
Right.
Yeah,
it's amazing.
And I think it's this idea of how well someone can do, how they can also protect their partners. We hear a lot about people that don't modify their behavior, but a lot of my patients are very cautious about sex at all, because they're worried about infecting other people. And there are really strong data now that both from randomized trials and from observational cohorts, really demonstrating this kind of undetectable means uninfectious or non-infectious.
Untransmissible.
Right.
Untransmissible. You equals you, right?
You
That's the
equals
thing.
you. Yeah, and I think that, when you're talking about talking to a newly diagnosed patient and telling them they're going to live a normal lifespan and you're not going to give this to your partners is incredibly liberating. And you can just see their faces, accept that news and just feel so much relief when you educate them about that. And it's such a good time to be
I agree.
providing
Five
HIV
years
care.
ago, the message was you're going to do great, and the only thing that's going to change is condoms.
Yeah.
But now you don't even have to say that
Right.
in the right clinical situation.